It's not recording. Is it? Okay,
No.
yeah, it's recording now. Yeah, okay.
Okay, I can see that.
Hi, Ben.
Hello, good to see you again.
Hi, I've got a case. It's a 13-year-old Pekingese, male
Hmm.
neutered. It's presented for an acute respiratory distress about 48 hours prior to the exam. He was treated using oxygen, and we've started pemobendin and benazepril. The
Okay.
owner has actually reported the dog has been coughing recently. There was no heart murmur auscultated on the physical exam. And we've done some chest x-rays and we found an enlarged cardiac silhouette with an elevation of the trachea and increased sternal contact, which suggests an enlarged right side of the heart. There's no enlargement of the left atrium on the x-ray. So I have attempted to do some echo views and I've captured the images and wanted to show you and ask for your opinion.
Okay.
So this one that I've chosen, I think I'm seeing like the left atrium and the aortic ratio. Is that correct?
Not entirely. In fact, you are looking at the aortic root, the aortic base root, which is at the center of the image. If I'll try to annotate that, can you follow? Hold on, let me try to use the annotations function if I can, but if I cannot, I will just try to guide you through this. Oh wait, I think I am able. Can you see my mouse right now? Can you see the arrow on the screen?
No.
No. Okay. Can you see that line?
Yes.
Okay. So what I did right now was to emphasize the aortic root. When we are unable to see the aortic valve leaflets or cusps, in fact, but this circle in the center of this image is the aortic root. To its right, where I annotate now, you see the pulmonary root, the pulmonary valve. And from here beyond, when you go this direction and that direction, these are the two pulmonary main branches, pulmonary artery branches. So the last one I annotated is the right branch, and the first one I annotated is the left branch.
Okay.
So I'm not sure how to delete what I've annotated. Maybe like that. No. Okay. If you go this direction, you're in the right ventricular outflow tract. If you go the other direction, you're distal to the pulmonary valve, and you're now only in the main pulmonary artery and its two major branches. Okay. So yes, it is the left base of the heart, and you are looking at the aorta, but you do not see the left atrium on this image.
Okay.
You are able, however, to see that the right pulmonary artery is a little wider, subjectively speaking, than the aortic root, and that does go along with the suspected right-sided enlargement. It would go along as if there might be some pulmonary hypertension present.
And can you tell that there's no left atrial enlargement then from this view, or do you need another view?
Not based on this view. Yes, they will be needing another view.
Okay, that's fine. And then for the second image.
Okay. Let's try to upload that. Are you looking for another echo image now?
Yes.
Or ready? Okay. I think it's loading right now.
Yeah. I see your mouth now.
Okay. This, I'm not entirely sure what the inset is showing us, but it looks like we may be looking at the tricuspid regurgitation jet in color. Yeah. I'll try to annotate that. No, sorry. Hold on. We're now looking at only a part of the image. So Okay, I can annotate this. I think this circle now encircles the right atrium.
Mm.
And the middle of the circle shows you a very small portion of the tricuspid valve leaflets, out of which comes a very narrow colored jet, colored Doppler jet. It goes from the top of the image to the bottom. And if I'm correct about the location, which I have yet to prove to myself, this means that the spectral Doppler is right in the middle of that jet. The sample volume is in the center of that jet, and the bottom part of the image. Let me come out of this and come back to it so that we can see the bottom part better. Okay. The sample volume that's inside the tricuspid vegetation jet is now represented by this baseline, which I am annotating right now. This straight baseline shows you how the flow functions along time. The x-axis is time. The y-axis is peak flow velocity in meters per second. So you can tell that you see several beats. Each of these signals is a heartbeat in systole. Most of them show a certain peak flow velocity, but the fastest ones, the ones I annotate at the moment, where this plus is, this one, that one, that one, and that one, are the fastest jets, or the fastest beats. And when you look at the peak flow velocity y-axis, you can tell that the peak flow velocity in these beats is about 4 meters per second. You can see that here. There is a modified equation by which you take this number, 4 meters per second, you multiply it by itself, and then you multiply it again by 4, and that gives you the systolic pressure gradient between the right ventricle and the right atrium. And this number, in fact, is already depicted on the image, and you see it right there. So that number is 73.14 millimeters of mercury. That's what the system has calculated for us. This means that the peak pressure gradient, the peak systolic pressure gradient across the sample volume, or in other words, between the right ventricle and the right atrium, is about 3 times above normal. Normal should be 25, maybe 30 at the very bad day, but 73 is almost 3 times as much. And that really attests or confirms the suspicion of pulmonary hypertension, which is of moderate severity.
Okay. So we have a diagnosis, but we're not sure about the cause yet.
Exactly right, yes.
And for the x-rays of the chest, can you also give me some second opinion on the cause, maybe?
I'm not really sure I can give you a certain assessment, but I think depending on the epidemiology in that area, there is a common lung disease or upper airway disease, which you may be familiar with, especially given that specific signalment and region. If there has been some chronic lower or upper airway disease going on, potentially explaining the chronic cough or the 1 week long coughing, that alone could sometimes generate as a secondary complication pulmonary hypertension. So I would call it reactive pulmonary hypertension. And if you're only able to treat the underlying airway disease successfully, I assume that the pulmonary hypertension will be reduced or even go away entirely.
Okay.
I think it's a secondary complication which does not necessarily need direct addressing right now, because I do not hear about any clinical signs associated with it. Okay. Unless somebody from the practice tells us about either exercise intolerance or syncope under excitement or exertion, or if there's any evidence of fluid retention, whether pleural effusion or abdominal effusion or subcutaneous edema. If none of these is present at the moment, I would not worry too much about pulmonary hypertension, but rather focus on the suspected underlying airway disease, upper airway or lower airway.
Okay. So I'll probably try and treat it as a chronic bronchitis case. I'll start doxycycline and a bronchodilator. And if the breathing is still showing some signs of difficulty, then maybe I will add nebulization as well.
Yes. If there's any option of giving oxygen at home, I'm not sure this is practical, but if it might be, it could help both the respiratory signs, if there are any, especially coughing, and it might also reduce the pulmonary hypertension without any pharmaceutical intervention.
Okay.
Because oxygen in and of itself will dilate, not only will it improve oxygenation, it will also dilate pulmonary arteries. And that on itself can reduce the pulmonary hypertension without any need of expensive drugs at this time.
And to follow up, do we need to repeat the echo and check for the pulmonary hypertension?
I think it's a good idea, yeah. Especially if the coughing resolves, even partially, in a few weeks' time. Yes, a repeated echo would be a good idea, just to see if the pulmonary hypertension is lower than it is now. I don't think it will be back to normal, but it should be reduced, say, to 60 or 55 or 50 millimeters of mercury. And if you see any such evidence, that alone will tell you that you're on the right track. I don't think the pulmonary hypertension is an emergency at the moment. But if right-sided congestive heart failure does develop, then it will become, maybe not an emergency, but it will become a new issue that needs to be addressed.
Okay, excellent. All right, thank you very much, Dan. Have a nice day.
You're most welcome. Thank you. You do the same. Thank you. See you.
Bye-bye.
Bye.